name's Hashim Ahmed. I'm a professor in urology and I'm also a consultant urological surgeon. It's been great. We've been waiting for something like this to come onto the market that differentiates itself from using a grid or the other devices. And the beautiful thing about this is a number of features really. First of all, the various steps and levels that you can use. Secondly, the ability to angle, and that allows us to reach anywhere in the prostate that we want to target. So it really gives you the flexibility to target accurately, to take systematic biopsies if you want to, and to use your existing tools that can integrate with the Pivot Pro. So I found it really useful so far. We did the first 3 cases in Europe a couple of weeks ago, and the histology on all 3 cases came back exactly as I would want it to. So all the targets came back as showing cancer. It means we didn't miss, and all the systematic biopsies didn't show any cancer either, but that can often be a random process. I found it very easy to learn. There is a learning curve, but it's very straightforward to use. So I hope a lot of people will give this a go because I found it extremely helpful and useful so far. For the last 2 decades, have been using the grid with a stepper. I've also used a IV cannula to do a double freehand targeted biopsy mechanism. That's quite fiddly and it requires a lot of expertise. And I've used a number of the competing devices that allow freehand, single freehand targeted biopsy transperineally as well. And so far really this has those advantages. So like I said, the ability to integrate with any ultrasound or image fusion system that you have, the ability to vary the level really makes a big difference, and the angulation is really critical. So I think those 3 features, as well as some of the cost benefit against some of the competitors, I think make this something that the UK urologists should strongly consider trying. Yeah, so it's like anything, you need to be able to do it a few times. So you should practice on a phantom. You should practice putting the Pivot Pro on an ultrasound and taking it off. You should, outside of the patient, practice changing the levels so that you can move the needle up and down. And it requires some finesse to that. And you need to practice moving the angulation as well. And what I found is, rather than fully tightening up the needle, keeping it loose, so allowing you to vary the angle, makes a big difference. The issues I have with freehand transperineal devices is the fact that you have to angle inside the rectum, and that angulation, when you do it, and if you do it too much, actually causes a lot of discomfort for the patient because you're angling against the anal sphincter. And it's the insertion of the probe and the angulation that causes a lot of discomfort to patients when you're doing it under local anesthetic. So I think this has that advantage over some of its competitors as well. So if you are trying to get really good images, you have to squeeze the prostate a little bit, and if you don't have the ability to move the levels up and down as you would want, then you end up trying to, with your hand, push against the prostate, and that causes the prostate to go from that sort of normal shape to a sort of squished shape, and then you're having to constantly change position or angulate and maneuver. So you can actually keep the pressure off, enough so that you don't lose the image quality and still reach bits of the prostate that you want to very accurately. I think the debate on transrectal versus transperineal should really be over. We have plenty of evidence that shows sepsis rates are lower. We have plenty of evidence that shows infection rates are lower. And the tolerability, whether you use a grid or one of these freehand devices to do transperineal, you are able to do it under local anesthetic, provided you've trained, provided you take it seriously, and provided you stick to a standard operating protocol for giving the local anesthetic that mean the patient can tolerate it. Patient safety, I think, is the key in terms of infection. And secondly, related to that is antibiotic prophylaxis. I do use antibiotics. I think in a big metropolis like London, you have to use antibiotics, because whenever we haven't, our infection rates have crept up a little bit. But in smaller cities, towns, you could probably get away without using antibiotics. But the key is, by avoiding infections, avoiding sepsis, you're then not hitting men with such a life-threatening complication. And secondly, in order to treat sepsis, you have to give quite hardcore antibiotics. And in terms of antibiotic stewardship, you really want to avoid that. I think there is an advantage with transperineal in hitting apical lesions and anterior lesions. Most of our cases are done under local anesthetic, so about 90%, and men tolerate it. What I didn't want to do is, when we started using a new device, is to go straight to a local anesthetic procedure, because there is going to be some learning about how to use the device. So we started off using general anesthesia, it could be sedation, but again, when you start off using these new devices, it's always worthwhile controlling for all other factors so that you're not having to do too many things all at once. First of all, we just have to make sure they don't feel faint, that they don't have any issues with passing urine. And so usually men stay for anywhere between 30 and 60 minutes. Yeah, I think the first thing to do is look at your own practice and just see if you're comfortable with what's happening with your own practice, but also who's doing the cases. Is it juniors? Is it nurse practitioners? Are they feeling comfortable with their current setup? And if there are issues, or if there are things in terms of efficiency or costs that you think could be dealt with, then it's definitely worth giving this a try.